Okay, good morning. So I'm Lena Merjanian. I'm an OBGYN over at Rutgers Robert Wood Johnson Medical School. And through my clinical practice, I've really developed an interest in adolescent gynecology. And so I'm very happy to be speaking here today about two topics this morning. The first one is about adolescent sexual health. And the second one is going to be about adolescent pelvic pain and how to really go through the evaluation of a young woman who comes in with certain complaints. No disclosures. So what are some of the things that we're going to be talking about today? We're going to be discussing really understanding the implications of adolescent sexual behaviors. We're going to discuss the importance of the contraceptive health visit in the adolescent patient. We're going to talk about some of the screening modalities for sexually transmitted infections. We're going to discuss about the importance of talking to patients about the human papilloma vaccination. And to give a little bit of an introduction about pre-exposure prophylaxis to the prevention of HIV, which is a sort of a new hot topic in the realm of HIV. So what is adolescence? Basically, it's the transitional phase of growth and development between childhood and adulthood. The World Health Organization defines an adolescent as a person who's between the ages of 10 and 19. The definition for young people expands to between 10 and 24. And the onset of adolescence really brings on new changes to a young woman's body and a new realm of experiences for her to be thinking about. So it's really important for us as providers to be able to educate our patients, really educate them about some of the means we have of sexually transmitted infection prevention, unwanted pregnancy prevention. Part of it is also adolescents may face barriers in even coming for help to us, and so it's so important when they're there that we're actually able to talk to them about many of the topics that are important. We really, at the end, want to help them make informed decisions about their body and responsible decisions about their overall health. So oftentimes my patients ask me, the moms ask, so I have a teenage daughter, when should they come to see you as a gynecologist? Our recommendation from ACOG says that a first visit for a young woman should be between the ages of 13 and 15. And when I say that, the moms are like, oh, but that seems so young. My daughter's not sexually active. Like, why do I have to bring her in? And the whole point of that visit is to establish a bond with a physician, for that young woman to know that there's somebody that, one, they feel comfortable with, and two, that they can come to and talk to about some very sensitive topics that they are going to be dealing with probably within the next couple of years of their life. In the world of OBGYN, our office hours are super, super busy, but what we do in our office for our adolescent patients is we always block off 30-minute time slots for them. As Dr. Wells has mentioned, you really have to be talking to your patient, and oftentimes it's the parent or the guardian who brings the patient in for that first visit. So usually the way the format of my office visit goes is I have the parent and the young woman together initially. I go through some basic questions with her. I always tell the parent that I'm going to have them step out for a little bit so I can have a separate conversation with the patient, and then I'll have the guardian or parent come back in. So it really does take that full 30-minute to be able to talk to adolescent patients about really important topics. It's really important to know, sometimes for the mom to know or for the mom to be able to communicate to her daughter, that not every gynecologic visit requires a pelvic exam. That's what our young patients are so scared about, is, oh my God, I'm going to go to the gynecologist and they have to do a pelvic exam. That's not necessarily true. It really depends if there's a clinical reason that the pelvic exam is going to give me any more information. But we will talk more so in the next lecture of the morning that I'll be giving about, when really is it indicated to do a pelvic exam on them. Like I said, we're really focusing on patient education in that initial encounter visit, unless the patient really does come in with a problem that she has. Like we talked about the HPV vaccine, we'll talk about it a little bit later as well. In terms of the frequency of the visits for the young woman to see a gynecologist, established care, we usually say every year you should come in. We can just update your health, go through some important things that may be going on with your life and things that we need to talk to you about, or if there's any other reason why they need to come in. Reproductive life planning, including the delay of onset of sexual activity and childbirth, is a really important part of counseling now, and you'll see in the slides why. So the gynecologic evaluation, not necessarily just the examination, but the whole gynecologic evaluation for the adolescent patient should go through some of these basic topics: menstrual disorders, pubertal growth, if there's any issues with pelvic or abdominal pain, and that's sort of the next talk. If a patient has concern about any vaginal discharge, vulvar rashing, any itching, and then contraception and sexually transmitted infections, which we'll go through in a little bit. So adolescent pregnancy rates in this country are the highest among developed countries. Although our incidence of adolescent pregnancy rates have decreased from the peak in 1990, which it used to be 117 pregnancy rate over 1,000 patients, it's now down to 57, but that's still high. When compared to Europe, the rate of sexual activity is similar, but it seems like in Europe they do have a little bit more access to education in sexual health and effective methods of pregnancy prevention. Quiz question: 3/4 of adolescent pregnancies are unintended. That's a lot. Over 75% of them are unintended. And we have such good methods of pregnancy prevention which is why it's so important to educate our patients. Childbearing and pregnancy is more likely among the economically disadvantaged adolescents, which obviously not only affects the patient herself, it affects her own family, it affects the community, it affects everybody actually involved. 60% of adolescent mothers do not graduate from high school, and only 2% complete college by the age of 30. Out of all the births of adolescent patients, about 17% are repeat births, so they get pregnant again. And so capturing patients even when they're pregnant and talking to them about postpartum contraception is so important to help decrease the repeat birth rates in our adolescent patients. Birth amongst adolescents costs about $9.4 billion more if they had occurred in an older woman, even though she's still in the young age category. So why do we think there has been at least somewhat of a decrease in the pregnancy rate? It's probably not because people are less sexually active. I mean, there is more education about it, but it probably is not the big factor about why we've recently had a decrease in rate. It's probably because we do have more effective contraception, and really the one that we're going to spending some time about are the long-acting reversible contraceptives, or the LARCs. And you can see how the rate of use of LARCs have tripled over the past several years. It's still a small percent, but it at least has increased. And I think it comes from education. Both on our end as providers, for us to be familiar with the methods, and for our patients to know and understand them. So social and behavioral factors that motivate adolescents to become more effective contraceptive users and less sexually active is unclear. But we do think that the rates are also affected by educational and career aspirations that students have, some mentoring programs, economic fluctuations, what we consider childbearing norms, contraceptive coverage with insurance, and really availability of health information through social media and TV is also helping to contribute to the decreased pregnancy rates. So what options are available to adolescents in terms of contraception? ACOG supports the use of all contraceptive methods that are available for the adolescent patients, which includes the intrauterine devices, the subdermal implants, the DMPA, which is Depo-Provera, combined oral contraceptive methods, and obviously barrier methods. In the absence of any medical contraindications, patient choice should really be what helps guide us in terms of telling a patient what which method might be the best for them. If a patient is not comfortable with the method that you prescribe to them, they're not going to use it. So that whole counseling session that you have with that young patient is really, really important, because if they're not comfortable, they're not going to do it. So how can we help them? These are the answers to one of the other quiz questions as well. So how can we help them make that choice for contraceptive? First of all, we want to find out what their reproductive health goals are, right? And if they don't want to get pregnant, then that's sort of where we need to focus our attention to. We do want to discuss contraceptive efficacy with our patients and the failure rates. It's important to know. And tomorrow actually is going to be my contraceptive update talk. We'll really go into a little bit more detail about that. Really important to talk to patients about side effects of medications and adverse effects of medications. If a patient knows that when they start a birth control pill that they may have some nausea and some breast tenderness for maybe up to 2 to 3 months when they first start birth control pills, when they know that, they're less likely to be worried when the side effect happens. But if they don't know that they're going to get nauseous, within a week they're going to call the office and say, I don't want to take this medication anymore. Or they're just not going to take it and they're not going to come in and they're going to get pregnant. So it's really that this counseling is so important. We want to dispel myths, misconceptions about certain side effects as well. Important to talk about some of the non-contraceptive benefits of certain birth control methods as well, which might help the patient make a decision about which one she would want to try. Of course, we always have to talk about the importance of barrier methods. Regardless of how effective the actual contraceptive method is, barrier methods are only the ones that are going to help prevent sexually transmitted infections. So patients also need to know that. And really to keep a sort of a broad reproductive health framework when we're counseling, to really not coerce a patient into a method, but really for her to have an idea of what are the methods available for her and what might work best for her. Oftentimes, whatever method I start, I do have the patient make a follow-up visit with me in a couple of months, usually in about 3 to 4 months, just for me to get a sense of how she's doing on the method and whether or not there's any side effects that we need to address, any adjustments that we need to make in the medication, and what other follow-up that we do need. So long-acting reversible contraceptives is really really an important topic for us to be talking to our adolescents about. And what the recommendations currently are is we really should be talking to our patients about the most effective contraceptive methods first. I think that's one of our quiz answers as well. And so long-acting reversible contraceptives like the IUDs and the subdermal implants are in that category. The satisfaction and continuation rates are high at 12 months. You can see that 81% of patients who have chosen a long-acting contraceptive method are continuing it after a year, as opposed to 44% that are non-long-acting methods as well, like birth control pills or whatever the case may be that's not a LARC. Patient and provider misconception pose a barrier to proper education is the key. Often in our department anyway, a lot of us OBGYNs walk around with little examples of what an IUD looks like. We put it on our ID and we just show it to a patient, like, this is the device that we're talking about, this is the IUD. And it's really important to explain to a patient, how do we put it in? What's the pain that's associated with it? What are the side effects to it? And how good of a contraceptive method it is. So you notice this is the IUD and this is how we place it. That's where it actually gets placed inside the uterus. And then there'll be those 2 little strings that stick out of the cervix. And then the subdermal implant goes under the skin of the arm. And nowadays there's more variety of IUDs coming out. Primarily, most of the IUDs are the progestin IUDs. There's also a copper IUD. And then the side effect profile is important to talk to patients about. But some of the newer progestin IUDs are also smaller in size. So they're more designed for a patient who's never had a baby before. I love my LARC. We do talk about this a lot in our patients. So Depo-Provera, DMPA is the abbreviation. You'll see it on some slides. It's convenient in terms of dosing it because a patient would have to come in every 3 months to get an intramuscular injection. So to some, it might be better than taking a pill every day. If used consistently, their efficacy is as high as the LARCs. But again, it takes some level of a patient coming in for the visits to actually get their injections, as opposed to having an IUD placed in their uterus that may be good for 3 to 5 years, or the implant, which is good for about 3 years. There had been some concern from studies that showed whether or not Depo-Provera had a risk to bone health for patients because of the hypoestrogen environment that the progesterone creates. And FDA had put a black box warning about continuing its use at one point. But we know that the bone effect is reversible, meaning if a patient needs to be on Depo-Provera for more than 2 years, it's fine. Because we know that once it's stopped, the bone effect does go away. You don't need to do any monitoring of the bones. You don't need to get DEXAs if the patient's going to be on it for more than 2 years. So it is safe to continue. There is a lot of weight gain that's associated with Depo-Provera, and I think that's really important for patients to know, especially some of the obesity epidemic is so high as well. And for a patient to know that they may gain 5 pounds a year on a method may not be acceptable to them. So things to think about. So combined hormonal contraceptives is probably what we're most comfortable with, even though this probably shouldn't be the first thing that we talk to our patients about. They do have a higher failure rate overall because, again, it's patient dependent, right? The patient needs to remember they need to wake up every morning or right before they go to bed and take their medication every day. And that might be hard for a young girl who's, in high school and has many activities going on. They may not remember it. And so if they took it properly, it would work well. But if they didn't take it properly, which they may not, that's where we're going to run into the problems. About half of adolescents have reported that at some point they've used birth control pills. The 1-year continuation rate for these pills are about 32 out of 100. So notice how we said the continuation rate for LARCs was so much higher. And some of the things I had mentioned before, the side effects are what may make a patient stop taking the birth control pill. And again, as long as you counsel them ahead of time that some of the side effects that they're having are normal, that will help increase compliance with the medication. And also, if patients know that, generally speaking, birth control pills can help with the acne, it can help decrease the flow of their cycles, it can help take away cramping, that may also make them want to take the pill in addition to the contraceptive benefits that they will obtain. So adherence, again, for many of these birth control methods is very, very important. It doesn't work if it's not used. Somehow I tell patients, put a reminder on your cell phone. There are so many apps that they can use to help track their ability to take their medications properly. There's online programs that they can, there's websites they can go to for daily, weekly, monthly reminders that they can receive about taking their medication. There's a website there that they can use. We think that these methods that are out there help, but we definitely need better studies to show that some of these adherence methods are going to help. So another thing that's actually really important, especially in our adolescent patients, but it actually holds true for all of our women when we talk about starting them on contraceptive methods, is the question is, how do we start them? Like, when do we start a patient on a birth control method, right? For somebody who's sexually active who needs the benefit of the contraception from it. It's really important that at the time that you start a woman on her birth control method, that you're reasonably sure that she's not pregnant. And if you look at the US Selected Practice Recommendations for contraceptive use from 2016, they actually have a whole algorithm of how can you how can you be reasonably certain that a woman is not pregnant at this time of starting the birth control method? And remember, for combined oral contraceptives, for the progesterone-only pills, we really don't have studies that show that there's a harmful effect for a woman to be pregnant and being on that birth control method. However, why would you want to put somebody on a birth control method if they're already pregnant and you don't know? It's obviously more of a problem, of course, if you're putting an intrauterine device in their uterus and they're potentially pregnant, you don't know about it. That's a no-no. But so how do we know? If a woman is within 7 days of the start of her normal menses, if you start her birth control method there, the chance of her being pregnant right then is low, right? Because they're already in their menses. If she has not been sexually active since her last menses, so the chance of her being pregnant would be low. If she is consistently and reliably using a contraceptive method, if she recently had a miscarriage or an abortion, literally if she's within 7 days, the chance of her, hopefully she hadn't been sexually active after having that event, but the chance of her being pregnant at the time is low. If she's within 4 weeks of being postpartum and has not been sexually active, or if she's nearly or fully exclusively breastfeeding. And exclusively breastfeeding means that the majority of the time, 24 hours a day, that they're actually breastfeeding, as opposed to formula supplementation and they're not breastfeeding consistently, because that could put them at risk for ovulating. So the Quick Start initiation is the algorithm. I know it's small, you can't really see it here, but if you do go to the CDC's website and just put in the Quick Start algorithm, it's actually a very useful tool to have to sort of get an idea how reasonably sure she's not pregnant at the time that you start them on a method. And that's really important, especially in our young adolescent patient, right? You have her in her office, you want to get her on a method that will be effective for her as soon as it can be. And so, you know, if you tell them, oh yeah, start it with your next period, who knows, if her next period's like 2 to 3 months from now, maybe she has PCOS or something, she's gonna risk getting pregnant. So it's really important to be able to be reasonably sure that they're not pregnant at the start of the conversation and starting them on a method as quickly that is safe for them. So what are some unique barriers in accessing contraceptive services? There are concerns, obviously. I can't tell you how many patients come in and they're just, you know, they're worried. They're like, oh, is my mom gonna find out? Is my dad gonna find out that I'm on birth control? You know, because oftentimes they're through their insurance and, you know, the cost of it, they're afraid of, are they gonna be able to afford the methods that we're recommending? You know, and I often tell them, I encourage them to be talking to their parents or their guardians about some of the concerns that they have, but they don't need to. It's also really important for patients to know, and it's part of that 30-minute time frame that I have with them, is to have that conversation with them where I ensure them that whatever they tell me is confidential between themselves and myself, and that I'm not going to be telling their parents some of the things that they're talking to me about, because that's what they're often worried about. Legal rights may vary by state and change over time. We talked a little bit about providing adolescents really the opportunity to discuss. It's not a one-way street when we have this conversation. It's really a dialogue between myself and the patient in terms of figuring out what's the best for them. Sometimes we do have to refer patients to Planned Parenthood, depending on what the insurance status is for the patient, for her to be able to access some of these methods. But it's also important to know that there are some very reasonably priced birth control options for patients to get through pharmacies as well, even if they don't have insurance. So what is CDC's recommendations in terms of screening for sexually transmitted infections and HIV? So all adults and adolescents from ages 13 to 64 should be tested at least once for HIV. And the frequency of further testing should be dependent on the patient. You know, just as a general practice for all my patients, whenever a patient comes in for an annual, I always offer HIV testing. And it's the patient's right to say, yes, I want testing, or no, that they don't want testing. And really, really important to talk to our adolescent patients about this, because they don't even realize they need to be getting some of this testing. Annual gonorrhea and chlamydia screening of all sexually active women younger than age of 25 is recommended. Or if they have risk factors that can put them higher risk for getting gonorrhea or chlamydia, if they have new or multiple sex partners, or they routinely don't use a barrier method to prevent some of these STIs. Another important thing to know about gonorrhea and chlamydia testing is that it currently is recommended that once the treatment is done by the patient, that we have them follow up about 3 months later to be retested for reinfection. It's really not to check if the original infection was cured, because our medications that we have work well, but it's really to make sure that they haven't been re-exposed to, say, chlamydia. So that follow-up is very, very important. And obviously, once a girl has one type of sexually transmitted infection, it's really important to talk to them about be screening for all sexually transmitted infections, not just limiting it to the test that you've already done. Anyone who has, like I had mentioned, unsafe sex practices or shares injection drug equipment should get tested for HIV at least once a year. Routinely for our pregnant women, we do syphilis, HIV, Hep B testing, along with gonorrhea and chlamydia testing for our pregnant women. Most of the blood work, we do it early in the pregnancy. We do HIV testing twice during a pregnancy, one in the first trimester and usually one in the third trimester. And if there's any other interval of testing that's needed for a particular patient, then obviously we would do that as well. For gonorrhea and chlamydia testing, urogenital infection can be diagnosed by testing first catch urine specimen or collecting a swab. Typically, the test that we've always done is the gonorrhea and chlamydia probe that we do, which usually requires a speculum exam, but there are urine tests that can test for the same bacteria. And so for a patient who really is hesitant about getting a speculum exam, that might be an option for them. There's also self-collecting, so the patient can actually insert the swab in her own vagina to collect for the specimen as well. And so if that makes them more comfortable to be able to get the gonorrhea and chlamydia test that they need, that's available as well. Let's switch gears a little bit and talk about the HPV vaccine. So the HPV vaccine protects against certain types of HPV strains that we know are associated with cervical cancer and genital warts. The most up-to-date vaccine right now is 9-valent, so it covers those HPV strains listed. 6 and 11 are the two strains that are most commonly associated with genital warts, and 16, 18, 31, 33, 45, 52, 58 are the ones that are associated with cervical cancer. And with the 7 strains that I just said there, that covers about over 90% of cervical cancer. Obviously, the vaccine doesn't treat existing HPV infection. If a patient has a particular strain, it's not going to treat this. Regardless of whether or not a patient has received her HPV vaccine, she does need her normal annual screening starting at the age of 21 with whatever frequency is appropriate for her age range. So currently the vaccine is recommended for young women and men between the ages of 9 to 26. The ideal age of receiving the vaccine is 11 to 12. That's a test question answer as well. It's currently a series of 3 shots that a patient would get over a 6-month period. So they would get one today, they would get one in 2 months, and they would get one in 6 months. However, the new recommendation for patients who are under the age of 15 is if they are under the age of 15 when they start the vaccination series, they actually only need to get 2 injections. They get 1 dose, and then they get their second dose 6 to 12 months later. There is no protocol currently for revaccination. So if somebody has, and currently the vaccine that is we're recommending is the 9-valent one. The one prior to this was the 4-valent one. But there are no recommendations right now. So if your patient received the 4-valent, nobody's saying that we have to give them the 9-valent now. If they start one of the valents, so if maybe your office had the 4-valent in stock originally, but the 9-valent came out, you can complete the series with the 9-valent as well. So just a little bit of epidemiology for HPV. 10% worldwide prevalence, highest in Africa. 20 million people in the US are currently infected with an anogenital strain of HPV. 5.5 million people in the year acquire new genital HPV infection. 3/4 of infections occur in our young patients, right? 15 to 24 years old. Almost 40% of sexually active 14 to 19-year-old girls and 50% of sexually active 20 to 24-year-olds are infected. 80% of sexually active men and women acquire genital HPV at some point in their life. So it's it's the highest, it's the most common viral sexually transmitted infection. What the concern about HPV, right, are the ones that are the strains that are the high-risk strains that are persistent, which can lead to changes on their cervix that can eventually lead to cancer. The good news is most of the HPV, the genital HPV strains, are transient, asymptomatic, and they don't have clinical consequences, except, of course, if you have the high-risk strain that is persistent and your body hasn't cleared it. Like we had said, the maximum effective age range for the vaccination is 11 to 12. The studies had showed that 1 month after completion of the HPV vaccine, girls ages 10 to 14 had a higher antibody level than those who received the vaccine at an older age, which emphasized the importance of getting the vaccine at the right age range. Currently, about a third of our 13 to 17-year-olds have received all 3 shots. About half of them have at least received 1 dose. I mean, we would like to, of course, these numbers to go up. If we increase coverage to 80%, 53,000 cases of cervical cancer can be prevented over a lifetime. And like I had mentioned, there's no current indication for a booster vaccine at this time, although if some studies show that a booster is recommended, that may change in the future. Parents always are concerned about the safety of the HPV vaccine, right? You know, the HPV vaccine's probably been out for a little bit over 10 years now, but parents are always concerned about them. They say, is it safe for my daughter or for my son to get this vaccination? And currently the safety profile we have is very good. Mostly the side effects are just the local side effects of pain, redness, dizziness, sometimes a little bit of nausea. We do have them sit in our office for about 15 minutes after the vaccine just to make sure that there's no syncopal episode that happens. But there's no studies that suggest that there's more severe side effects than some of the local side effects. Parents think, oh, my child is not sexually active. Why do I need to give them something that's going to make them sexually active, right? Again, it's sort of the misconception that if you talk to them about HPV and you vaccinate them, that it's going to encourage a patient to become sexually active. That is not true. This whole point of this is you're supposed to get this vaccine before you're sexually active to get the maximum benefit from the HPV prevention. This study had really showed that the outcomes that are associated with becoming sexually active is not different after receiving the vaccine. Provider counseling is key, and oftentimes patients need to think about it, right? Sometimes I say, okay, here's some pamphlets, I spoke to you about it, here's some pamphlets, read about it, think about it. If you're interested, come back. And I find that patients, you know, once they think about it a little bit longer, they may not be able to make the decision at the time, but they do often come back for at least starting the series. So the other hot topic that I just wanted to mention now is pre-exposure prophylaxis, or PrEP, for the prevention of HIV. So why are we talking about this in the adolescent setting? So women account for 1 out of 5 new HIV diagnoses. The U.S. Public Health Service recommends clinicians evaluate the patients who are sexually active or who are using illicit drugs, and considering offering them PrEP as a prevention option if they are at high risk of acquiring HIV. So some of the populations, like we mentioned, men who have sex with men, men and women in heterosexual HIV discordant couples, IV drug users, and like we said, those who have practices that of unsafe sex. Several trials have demonstrated the safety and substantial reduction in the rate of HIV acquisition with the use of PrEP. According to the World Health Organization, AIDS is the leading cause of death among adolescents in sub-Saharan Africa and second leading cause for adolescents worldwide. 50,000 people get infected with HIV every year in this country. 1 out of 4 of these new infections occur in our young age population. So this is part of the reason why that visit with the gynecologist or with, you know, the pediatrician is really important for us to be talking to our patients that this exists, like this happens. Why are adolescents at increased risk for HIV? You know, they're obviously physically, emotionally going through a lot of changes in their body, and, you know, they're going through establishing identity. There may be issues with power imbalance. They may be coerced into having sex when they're not ready or they're not protecting themselves. There may be some gender inequality, sometimes interpersonal violence in relationships that can expose a patient to HIV. Obviously, like for much of what we do in medicine, prevention is the key, and so that's why education about practices that reduce HIV transmission is so important. But also for patients to be aware that there currently is a method that may help prevent HIV. But again, remember, it has to be used in the setting of proper practices, right? You know, we don't want a patient to think that if they're a candidate to get PrEP, that they should be having unprotected sex and sharing needles when doing drugs, right? So this has to be used in the context of behaviors to help reduce HIV transmission. And then, you know, if a patient is diagnosed with HIV, to be able to have the services, to have the subspecialists, the counselors to be available to help them. So the medication that currently is recommended for PrEP is Truvada, which is a combination of two antiretrovirals, TDF and FTC. So just recently, the FDA approved PrEP with Truvada for adolescents and adults who weigh at least 35 kilos. Prior to this, there actually were no studies for the adolescent population. So some of the things to think about prior to starting a patient on PrEP is you should exclude current HIV, so you do need to recommend testing. You should reassess for HIV every 3 months while they're on this regimen. You should check baseline renal function prior to starting them on Truvada, and at least checking them every 6 months for renal function. Some of the common side effects that can happen with taking Truvada are headaches, abdominal pain, weight loss. But it's generally well tolerated. So again, this is for the, and the other important thing about PrEP is the patient has to be taking it every day. All the studies are showing that this works if it's taken daily. So it's a medication that a patient who is at high risk of HIV acquisition can possibly take to prevent HIV in the context of all the other things that we know help prevent HIV. Any questions? Mm-hmm. Yeah.
Insurance coverage is available with that preventative medication that you found?
It's expensive, so it is expensive. I believe some insurances do cover it.
What about Medicaid? You know, in your experience, because a lot of my higher risk patients are patients that have Medicaid or are not insured at all, so.
Right, you know, I'm actually not sure of the details for particular Medicaids. All I do know is, you're right, it is expensive, but we also will refer them to our HIV counselors, and maybe there are some assistance programs for it. I saw another hand up. Oh, with the box.
Yeah, question, the urine culture or urine testing for gonorrhea and chlamydia, we discussed this in our group a couple weeks ago.
Mm-hmm.
The data that we could find supporting that was on testing in males,
Mm-hmm.
and they extrapolated the female.
Yeah.
Do we know if it's as accurate for women?
I don't think we can say it's as accurate. I think it's an option for the very hesitant patient. There are patients who just won't let you do a pelvic exam, and you would like to recommend some level of testing, and if I can't do one test, that may be an option for them.
Yeah, I would think self-swapping may be a whole lot better
Mm-hmm.
test if we don't have data for men, or for women on
yeah.
this, because I
Yeah.
just don't think we can trust it for that.
Yeah, yeah.
Hi, for the HPV vaccine,
Yes.
Hi. For the HPV vaccine, if they're immunodeficient, does that change the dosing and how
No.
often?
No.
It doesn't. Okay, thank
No.
you.
In regards to the statistics on the teens and pregnancy compared to other developing countries, do you know what their use of LARC methods are in other developing countries?
I think they use I don't know the actual numbers, but I do believe that it's used more frequently and patients are having better access to it. Like I know even in our office, it's a little bit of a struggle for some of our types of insurances because we don't stock the devices in our office. And so if their insurance doesn't cover it, I can't provide it to them, which is why we need to refer them to a place like Planned Parenthood that can do it. So yeah, insurance and cost is a huge part of the problem that we have with some of these things that I've talked about.
Good morning. Do you have concerns about using Depo-Provera in underweight or normal weight developing adolescents or athletic adolescents?
There are, we'll actually talk about a little bit more of, where did the question come from? I'm sorry, I didn't see the person. Oh, I'm sorry. We'll talk about some of the things that help you figure out whether or not a certain patient is a candidate for contraceptive methods in my talk tomorrow, because the USMEC has guidelines for patients. There are no guidelines that say you can't give it to a patient who's underweight. So again, all of what we do in medicine oftentimes is you have to take into account the actual patient that's sitting in front of you, not just necessarily the recommendations that we have out. But there are no differences right now.
Right here.
For HPV vaccines, if you give the patients the first one under age 15 and then they lapse, is the recommendation just for one more whenever they can catch up, or do we have to do the two?
No, you should give the 2 additional so if they only got 1 prior to the age of 15, you should complete it with the two others, so it's a total of 3. The 2 doses only if everything is done under the age of 15. Did I see another hand?
So on the swab, like if they're going to self-swab, did they use the same, like the DNA swab that we would use for endocervical? Is it that same?
Yeah.
Okay.
Yeah. I find that I don't use, generally speaking, I think when patients have come to see me, I find that when I'm able to talk to them, establish that rapport with the patient, especially the one who's been sexually active that I do need to do the STD testing on, they allow the exam. The ones I struggle with are some of the patients who sometimes have mental disorders that they can't even sit still for an exam. Like I find that otherwise, most of my patients allow me to do the traditional testing that is needed, but it's just good to know some of these options that are available.
I have a question about confidentiality in teenagers with the bane of our existence, EMR and parental access to portals.
Yeah.
I really find a huge struggle because often in a paper note, no one could read my handwriting and the parent couldn't see it. And you don't want to not put the pertinent information, so when you refer back, but a parent can go on and read your note that day and know their child is sexually active.
Yeah, I mean,
Suggestions?
I think we need to document what's medically accurate for the patient. And, if my patient is sexually, I document it. I haven't quite had a problem yet where a parent has come and said, oh, why did you write this about my, I'm sure that can happen, but I just feel like if there is medical facts that are important to document, I will document them. If there's extraneous stuff that I don't need to put in there, I try to avoid that. I don't know if anybody else has recommendations about that. Yeah, I don't know. I don't know if we have. I don't think our system has a.
In our EMR, when you go into the portal, you don't have access to physicians' notes. You only have access to. I'm sorry.
I know in our EMR, and I'm not sure, I think they're all different, which is a huge problem, but in our EMR, you don't have access to our notes. The only thing you can see are lab results and test results that we have signed off on. Unfortunately, I do think they probably have access to medications.
They have, in some portals, how many people have a portal where they have access to notes? It's somewhat voluntary, but you can, in our portal at least, put in a confidential section, and so they wouldn't have access to that. Does anybody else have one of those, or do they have access to your whole notes? Someone want to speak to that?
We just have something that says share with patient, and you can like unhighlight it. So I always get it.
All right, anybody else have any other comments?
We don't. It's good to know.
Oh, I just said in our Epic system, there's something that says, share with patient, and it's bold, always bold. I always just unbold it for those circumstances.
Question for the audience. I've been asking this one for a number of years now. It's interesting to see. How many people have children who have been vaccinated for HPV? All right. How many people have children who are in the age and have chosen not to? Okay, thanks.
So I have a string of patients recently who have had a lot of pelvic pain with their IUDs, mainly in the adolescent population, and I feel like despite the amount of education that I give them over how long it takes to develop the uterus to get used to the device, what are your recommendations or your thoughts about like that population and the pelvic pain associated with IUD placement? Because I really try to push implants and IUDs with my patients, but I feel like I always worry that in 3 months they're going to be like, please take this out of me, and I try to coerce them into keeping it, but it's very frustrating when they come back in and they're like, just take it out. And I'm like, no, it's $2,000, keep it in.
I know that's tough. I mean, I think a bulk of the importance of it is the counseling that we have prior to placing the IUD. If I start talking to a patient about an IUD, sometimes you can literally see them look like deer in headlights. Like they want nothing to do with the IUD. I will continue my conversation with them. I'll let them simmer, think about it a little bit, but I may move on and say, you know what, maybe there's another method that we can start with. So if there's sort of like that to start with, that is not the patient I'm going to push, even though LARCs are the way that what we should be discussing first. I often tell patients to take Motrin prior to coming in. I describe the procedure to them like before they come in for that visit that day. Like they know in their head, hopefully, enough to get an understanding of what the experience is going to be like. I don't know. I haven't found that they're particularly having more pelvic pain with the IUD. You might want to think, I don't know which IUD you actually use, if you use some of the smaller ones that are out. But I think the counseling is really, really important.
Sorry, sort of in a similar vein. For your young teens, how do you balance patients who want to avoid a pelvic exam, so may not be a candidate for an IUD, versus Nexplanon? In my experience, the side effect profile is not that great. At least for my patients, I don't think it's 80% continuation for Nexplanon. We're taking more out. So would that be a place for Depo? And also, do you pre-medicate with side attack for your teens or your?
Not routinely, okay. No, and there's no recommendation to routinely pre-medicate with side attack. I mean, I think going to Depo-Provera, again, it's patient dependent. Mm-hmm. If she's okay with the side effects, and primarily it's the weight gain that I'm concerned about with many of my patients with the Depo-Provera, for them to understand that, and if they make that choice, then if they're otherwise medically safe to get it, then I think it's okay. I agree with the Nexplanon. And I know the package insert doesn't really talk about the weight gain as much with the Nexplanon, like the Depo-Provera, but I've had so many patients who do gain a significant amount of weight. And so that's my personal preference to not be, I talk to them about it, and if that's what they want, they get it. my preference is the IUD if I can, but if I can't, then to talk about the other methods. It's hard. Each patient is you have to just individualize their regimen to each patient.
I was just going to make a comment about the pain that the adolescents sometimes come back with. I don't think there's any recommendation for this, but I have sometimes almost more with the bleeding than the pain, and I think sometimes that goes hand in hand. If they don't have a contraindication, I'll put them on a birth control pill for the first few months and then take them off the pill and see if that gives them a little bit more control while they settle in. This way they're not really dependent on the pill for the birth control, but I can sometimes eliminate some of the side effects, and sometimes they will hang in with it a little bit longer. I don't know if anybody else has tried that. I've had it work.
I was wondering if you experienced sort of a negative bias among gynecologists or obstetricians in the community in regard to LARC in adolescents. And I asked because we had a medical student at the University of Pittsburgh who did a secret shopper survey, basically posing as an adolescent looking for a LARC, calling gynecology offices, and basically, and I don't know if it was a front office versus the doctor level, saying that we would not do that in someone your age, and very negatively biased and discouraging it. So didn't know, and I know there's very low uptake of LARC despite its effectiveness in the adolescent group. So just wondered if you've experienced that and people getting referred to you.
I mean, I think it even starts prior to the LARC issue. There are many gynecologist offices who actually won't accept young patients as patients to their practice. And, I think I can at least just speak for my own practice where, we do see the youngest of the young patients that need it. And I think we generally are advocates for the LARCs. Hard for me to speak about, community doctors, because exactly what you're saying is patients even have a hard time getting in for an appointment, let alone getting a LARC placed in them.
Just wondering what your opinion is of using tamoxifen for a short course on patients with Nexplanon who have abnormal bleeding or who have continuous bleeding with it. Have you used much of it? Yeah.
Never. I actually have not heard of that regimen.
Oh, okay.
I don't know. Anybody else have thoughts about that? I've never heard of that.
Here, over here. Here, over here. Ma'am.
The box.
I was going to answer to that question.
Yeah.
I'm a women's health nurse practitioner. We use short course of estrogen to stabilize the lining, like a low dose of estradiol, 1 milligram or 2 milligrams for 6 to 8 weeks for the breakthrough bleeding with Nexplanon. And
I
that
think
works
the question
really well.
was tamoxifen, right?
Yeah, I was just going to say it's an alternative.
yes.
I've never heard of tamoxifen either.
Okay.